Welcome to the deep dive. We've got quite a stack of notes and guidelines here today.
We do. And the plan is basically to cut through it all and pull out the really essential stuff.
Exactly. Today we're diving into contraception. So if you need to get up to speed quickly for revision or, for your clinical work, this is for you. We're focusing on the key methods, how they work, and importantly, those considerations for different individuals.
Yeah, we've pulled from material covering the basics right through to pretty detailed guidance for people with specific health conditions. And a lot of that hinges on things like the UK medical eligibility criteria, the UKMEC. It's a really core framework.
Right. So our mission today is to distill all that. We want to give you the high-yield facts, the clinical pearls from this material, hopefully in a way that's, well, easier to remember than just reading notes.
Think of it as a bit of a shortcut to getting well-informed on contraception based on these sources.
Okay, so let's start by unpacking the main types of contraception that are laid out in the sources. They break them down into a few key groups.
They do. You got your barrier methods, daily methods like the pills, then the long-acting reversible contraception, LARCs, that's a big one.
LARCs include things like the implant and coils, right?
Exactly. Implants, injectables, the IUS, the IUD, and then finally there's emergency contraception.
Got it. So let's start with the simplest one mentioned, barrier methods. Condoms, basically.
Yeah, pretty straightforward. It's
Yeah.
a physical barrier, stops sperm meaning egg. Now, the notes do flag a limitation here.
Okay.
Their typical use success rate isn't as high as some others, particularly, it seems, for younger users. But, and this is a huge point, they're the only method here that also helps protect against STIs.
That's a really key advantage, yeah. Okay, moving to the daily hormonal options. The classic one is the combined oral contraceptive pill, the COC. How does that work primarily, based on the sources?
So its main action is inhibiting ovulation. It stops the egg being released. Simple as that. Well, in principle.
But there are risks mentioned too.
Yes, definitely. The notes point specifically to an increased risk of VTE, venous thromboembolism, so blood clots, and also a slightly increased risk of breast and cervical cancer, things you absolutely have to discuss.
Right, important context. Then there's the progestogen-only pill, the POP. The sources seem to differentiate between types.
They do. For most POPs, the ones without disogestrel, their main mechanism isn't always stopping ovulation reliably in everyone. It's more about thickening the cervical mucus.
Ah, so creating a barrier for sperm.
Exactly. Makes it much harder for sperm to get through. The notes also mention irregular bleeding as a pretty common side effect with these traditional POPs.
And what about the disogestrel-only pill? How's that different?
Oh, right. So this one acts more like the combined pill. Its primary job is inhibiting ovulation, plus it also thickens the cervical mucus.
So a kind of double action.
Yeah, which contributes to it being very effective.
Okay, got it. Now let's talk about LARCs. These are popular because you don't need to remember them every day. First up, the injectable, like Depo-Provera, medroxyprogesterone acetate.
Yeah, the injectable. Its main action is inhibiting ovulation, and like some POPs, it also thickens that cervical mucus. The key thing everyone remembers is its duration. One shot lasts for 12 weeks.
12 weeks, okay. And then the implant, etonogestrel, like Nexplant.
Right, the implant.
Yeah.
Also primarily stops ovulation and thickens mucus. But this one's even longer acting. We're talking 3 years of cover.
3 years, that's significant. Any common issues mentioned?
The notes specifically highlight irregular bleeding. It's very common, especially initially, so it's really important to counsel people about that possibility.
Good point. Okay, what about the IUS, the intrauterine system, the hormonal coil releasing levonorgestrel?
So the IUS, it works a bit differently from the other hormonal methods we've covered. Its main effect is actually inside the uterus. It prevents the endometrium, the womb lining, from building up.
Making it unsuitable for pregnancy to implant.
Precisely. It also has that secondary effect of thickening cervical mucus. And again, like the implant, irregular bleeding, especially in the first few months, is flagged as a frequent side effect.
Okay. And the last one in this main group, the non-hormonal option, the copper IUD.
Right, the copper coil. This one works mainly by affecting sperm. The copper ions create an environment that decreases sperm motility and their survival chances within the uterus and tubes. Basically stops fertilization happening.
That covers the routine methods pretty well. The notes also go into emergency contraception, EC. How do those work?
Well, for the oral EC methods, levonorgestrel, sometimes called the morning after pill, and upropistal acetate, or UPA, they both work primarily by stopping or delaying ovulation. If the egg isn't released, pregnancy can't happen.
And UPA works a bit later in the cycle.
Yeah, that's the idea. It seems to have a slightly longer window of effectiveness before ovulation.
And the copy IUD that can be used for emergency contraception, too.
Absolutely. And the notes really stress how effective it is for EC. When used this way, its mechanism is described as being toxic to both sperm and the egg.
Ah, so it affects the egg, too, in that scenario.
Yes, and it also inhibits implantation if fertilization has somehow already occurred. Because it can work after potential fertilization, it's highlighted as the most effective EC method available.
Interesting how its primary mechanism seems slightly different depending on when it's used ongoing versus emergency.
It really shows how these devices can interact with our physiology in complex ways. Understanding these mechanisms is, well, it's the foundation for applying all the guidance on who can use what safely.
Which leads us nicely into the specific guidance for young people. This is drawn from FSRH guidelines mentioned in the sources, and it touches on some really key legal and ethical points.
It really does. So in the UK, the age of consent for sex is 16. But importantly, health professionals can provide confidential advice and contraception to someone younger if they assess that young person as being competent.
Competent to understand the advice and what it means for them.
Exactly. And that assessment often uses a framework known as the Fraser Guidelines, or Fraser Competence.
Right, I've heard of those. What do they involve?
Well, it's a set of 5 points. The professional needs to be satisfied about all of them before providing contraception to someone under 16 without involving parents.
Okay, what are the 5 points?
Okay, first, the young person understands the advice.
Mm-hmm.
Second, you can't persuade them to tell their parents or let you tell them. Third, they're likely to have sex or keep having sex anyway with or without contraception.
Right.
Fourth, their physical or mental health is likely to suffer if they don't get contraception. And fifth, crucially, it's in their overall best interests to receive the advice or treatment without parental consent.
Applying all 5 of those.
Thank
That
you.
sounds like it requires really careful judgment and a sensitive conversation, a real balancing act.
Absolutely. It takes skill and a very careful consideration of the individual situation. And the notes add another vital point. If you're talking about sexual intercourse with anyone under 13, that automatically triggers child protection considerations.
Essential safeguarding point. What about STI testing advice for young people? Say, after unprotected sex.
The guidance mentioned in the notes suggests advising tests at 2 months, and then again at 12 weeks after the episode of unprotected sex.
Okay. And choosing a method for younger people. The sources seem keen on LARCs.
Yeah, they point out that LARCs often have an advantage because, well, let's face it, remembering a pill every single day can be tough, especially for younger people. A method that works without daily input can be much more effective practically.
Makes sense. But are there any specific caveats or concerns with certain LARCs for this age group mentioned?
There are a couple of points flagged. One is about the injectable Depo-Provera and potential effects on bone mineral density, especially with longer use in adolescents whose bones are still developing. And also, both the IUS and the copper IUD are listed as UKMEC Category 2 for those under 20.
And UKMEC 2 means, remind us quickly.
Category 2 means the advantages of using it generally outweigh the theoretical or proven risks. So they can be used, but it's just maybe pausing to consider if other methods might be a slightly more straightforward first choice if they're suitable and the person wants them.
So given those points, do the sources lean towards a particular LARC for young people?
Yes, based on this material, they identified the progestogen-only implant. Nexplanon is the common brand as the LARC of choice for this group. It's long-acting, highly effective, and doesn't have those specific bone density concerns of the injection or the UKMEC2 listing for the under 20s like the IUDs.
Right, that's clear. Okay, now we get to what you called the backbone earlier, the UK Medical Eligibility Criteria, the UKMEC. This seems absolutely critical for applying the guidance, especially when people have other health conditions.
It really is. It provides that structured way to think about safety. The UKMEC is basically a system adapted from WHO guidelines for assessing cautions and contraindications for different contraceptive methods based on specific medical conditions or personal characteristics.
And it uses those 4 categories. Let's really nail down what each one means, because they crop up constantly in the rest of the notes.
Good idea. So
This is simple. No restriction. The method is safe to use. Go ahead. Category 2. Here, the advantages generally outweigh the theoretical or proven risks, so it's usually fine, but maybe worth a bit more thought, considering alternatives, especially if there's a UKMEC 1 option they like.
Right, a slight pause for thought.
Category 3. Now we're getting serious. The risks generally outweigh the advantages. This method is not usually recommended. You should really be looking for an alternative. Using it requires careful expert judgment and monitoring, if at all.
So generally avoid Cat 3.
Pretty much. And category 4, this is the strongest warning. An unacceptable risk to health. The method should not be used. It's a contraindication. Full stop.
So 3 and 4 are the main ones telling you, stop, don't use this method for this person. That framework really helps standardize things.
Absolutely. It takes potentially complex information about risks and interactions and gives you a systematic way to apply it. And the rest of the notes we're looking at essentially apply this UKMEC system to various specific health conditions.
Okay, let's do that then. Let's apply the framework. How do common conditions affect contraceptive choice according to these UKMEC categories? Starting with obesity.
Right, obesity. For people with obesity, the notes say intrauterine methods, so the copper IUD and the hormonal IUS and also the progestogen-only implant are generally UKMEC 1. Safe and effective, weight doesn't seem to be a major issue there.
And other methods.
The progestogen-only injectable is usually UKMEC 1 too, but the notes flag a specific situation. It becomes UKMEC 3 if obesity is just one of several cardiovascular risk factors that person has. So context matters there.
Okay. What about the pills?
The traditional progestogen-only pill is UKMEC 1, but combined hormonal contraception, the combined pill, patch, or ring, that's different. The risk of blood clots, VTE, increases with BMI.
Right.
So CHC is UKMEC 2 if the BMI is between 30 and 34. But if BMI is 35 or more, it jumps to UKMEC 3. The sources state the risks generally outweigh the benefits at that point.
So weight really impacts CHC choice.
Yep.
What about emergency contraception for women with obesity?
This is a really important practical point from the notes. The copper IUD is UKMEC 1 for emergency contraception. Its effectiveness isn't affected by weight, and it's stressed as the most effective method anyway.
But the oral options?
Oral EC seems less reliable. Levonorgestrel EC looks less effective if BMI is over 26 or weight over 70 kilograms. Ulipristal acetate, UPA, might be less effective if BMI is over 30 or weight over 85 kilograms. The sources really emphasize this potential reduced effectiveness and strongly recommend the copper IUD as the best bet for EC in women with higher BMI or weight.
That's a critical takeaway. And after bariatric surgery?
Yeah, after weight loss surgery, absorption of anything taken orally can be unpredictable. So oral contraceptives, oral EC, their effectiveness could be compromised. Non-oral methods are generally preferred. And the notes also mention stopping CHC at least 4 weeks before any major surgery, like bariatric surgery, because of that VTE risk.
Okay, good points. Let's move to enzyme-inducing medications. Sounds like these could cause major issues with hormonal methods.
They definitely can. These are drugs that basically speed up the liver's breakdown of hormones. So the contraceptive hormones get cleared from the body faster, reducing their effectiveness. Classic examples mentioned are rifampicin, some anti-epilepsy drugs like carbamazepine, phenytoin, some HIV meds, and even St. John's wort.
So if someone's taking one of these, what are the safe contraceptive options according to the sources?
The key is methods not affected by liver metabolism. So the copper IUD, the LNG IUS, hormonal coil, and the progestogen-only injectable are all UKMEC 1. Their effectiveness holds up.
Right. And what about emergency contraception in this situation?
The advice in the notes is for a higher dose of levonorgestrel EC 3 milligram instead of the usual 1.5 milligram. Ulipristal acetate, UPA, is not recommended if someone's taking enzyme inducers or has done in the last 28 days. Its effectiveness is likely reduced. Again, the copper IUD is unaffected and a great option here.
The notes also mentioned lamotrigine and grisafulvin specifically.
Yeah, slightly different scenarios. Lamotrigine is an anti-epileptic, but CHC can actually reduce lamotrigine levels, which could worsen seizure control. And stopping CHC can cause lamotrigine levels to rise, risking toxicity. So CHC is UKMEC 3 with lamotrigine. POP is UKMEC 1, but levels might need monitoring. Grisafulvin, an antifungal, is an enzyme inducer and can affect CHC, POP, and the implant, making them all UKMEC 3. So avoid those hormonal methods.
Really highlights the need for a thorough medication history.
Yeah.
Okay, migraines. This sounds important.
Absolutely critical. And the type of migraine is key. For just regular headaches, not migraines, all methods are generally UKMEC 1. Fine.
But for actual migraines?
For migraine without aura, you can start one on CHC. It's UKMEC 2. However, if migraine without aura develops while they're on CHC, the guidance says stop it. CHC becomes UKMEC 3 then. Most other methods are usually UKMEC 1 or 2.
Okay. And the big one, migraine with aura.
Right. Migraine with aura already carries an increased stroke risk. Adding CHC increases that risk further. So the notes are crystal clear. CHC is UKMEC 4, unacceptable risk. Should not be used.
Even a past history.
Even a past history of migraine with aura within the last 5 years makes CHC UKMEC3. Maybe even longer ago, depending. The main message is aura and CHC are a definite no-go. Other methods like POPs, injectables, implants, IUDs are generally fine UKMEC 1 or 2.
Wow, okay. So migraine with aura equals no CHC. What about diabetes?
If someone has diabetes but no signs of vascular disease, no damage to blood vessels in eyes, kidneys, nerves, etc., then most methods are UKMEC 1 or 2. Generally okay.
But if there is vascular disease,
If there is vascular disease associated with the diabetes, then CHC becomes UKMEC 3. The combined cardiovascular risks mean the dangers generally outweigh the benefits. Other methods usually stay UKMEC 1 or 2. Interestingly, a history of gestational diabetes doesn't restrict future choices. All methods are UKMEC 1 then.
good to know. And hypertension, high blood pressure.
Similar logic really focused on cardiovascular risk, especially for CHC. If someone has high blood pressure but no existing cardiovascular disease, their BP is 160/100 or higher, CHC is UKMEC 4, contraindicated. If their BP is controlled with meds, or it's in the 140/159 over 90/99 range, CHC is UKMEC 3. Not usually recommended. Other methods are generally UKMEC 1 or 2. If they do have existing cardiovascular disease on top of the hypertension, then CHC is definitely UKMEC 4, and the injectable also becomes UKMEC 3.
Right? Smoking, another big cardiovascular risk factor.
Yes, and here age interacts with the smoking status. For any smoker, regardless of age, methods other than CHC are usually UKMEC 1. Safe.
But for CHC?
For CHC, if a woman is 35 or older and smokes 15 or more cigarettes a day, CHC is UKMEC 4. Unacceptable risk, mainly cardiovascular events like heart attack, stroke.
15 cigarettes is the threshold there.
Seems to be, according to these notes. If she's 35 or older and smokes fewer than 15 a day or stopped less than a year ago, CHC is UKMEC 3, still generally best avoided.
Very specific criteria. What if someone has multiple cardiovascular risk factors combined, like smoking plus diabetes plus high BP?
The notes cover that. If someone has several significant risk factors combined, the sources say both CHC and the progestin-only injectable become UKMEC 3. The cumulative risk is too high. Other methods, POPs, implants, IUDs, generally remain UKMEC 1 or 2.
Makes sense. Okay, let's talk about VTE risk blood clots in the veins.
A major concern with combined hormones. If someone has a history of VTE, a current clot, even if treated, or is facing major surgery with prolonged immobilization, CHC is UKMEC 4. Absolutely contraindicated.
What about family history?
A family history of VTE in a close relative under 45 or significant immobility not related to surgery makes CHC UKMEC 3. But here's a really key point from the notes.
Yes.
Unlike combined hormones, the progestin-only pill is not linked to increased VTE risk. So PRPs, implants, injectables, IUDs are generally UKMEC 1 or 2, even with VTE risk factors.
That's a vital distinction. PLP is okay regarding VTE risk.
Right.
Okay, how about issues like menorrhagia, heavy periods, and fibroids?
Right. For heavy periods with no known cause, what they call idiopathic menorrhagia, most methods are UKMEC 1 or 2, and the LNG-IUS, the hormonal coil, is actually highlighted as a first-line treatment for the heavy bleeding itself, as well as being contraception.
So it does both jobs.
Exactly. But if there's unexplained vaginal bleeding where you don't know the cause yet, you should not insert a copper IUD or LNG-IUS. That's UKMS4.
Because you need to find the cause first.
Precisely. If one's already in place, you can usually leave it while investigating. That's UKMEC 2. The implant and injectable are UKMEC 3 if bleeding is unexplained. Other hormonal methods, UKMEC 2. The absolute emphasis is investigate unexplained bleeding thoroughly first.
Okay. And fibroids?
Depends if they distort the uterus. If fibroids are there but the uterine cavity shape is normal, everything's usually UKMEC 1. But if the fibroids do distort the cavity, inserting an IUD or IUS might be difficult or risky expulsion perforation. So copper IUD and LNG-IUS become UKMEC 3 in that situation. Other methods like pills, implant, injectable remain UKMEC 1.
Got it. Nearly there. Sexually transmitted infections and pelvic inflammatory disease, PID.
Okay. If someone had PID in the past but has no current STI risks, all methods are generally UKMEC 1. However, if there's current active infection, PID, symptomatic chlamydia or gonorrhea, purulent cervicitis, you absolutely must not insert an IUD or IUS, that's UKMEC 4, risk of spreading the infection upwards.
And if an IUD is already in place when injection is found?
The notes suggest you can usually leave it in place while treating the infection, UKMEC 2, though clinical practice might vary slightly there. Other hormonal methods, pills, implants, injectables, are UKMEC1 because they don't involve uterine insertion.
What if chlamydia is found, but it's asymptomatic?
If it's asymptomatic chlamydia, initiating an IUD is UKMEC3, still a risk of ascending infection, though less than with symptomatic disease. If one is already fitted, leaving it in during treatment is UKMEC2. Other hormonal methods are still UKMEC1, general vaginitis, other STIs, not HIV hepatitis specifically in these notes, or just increased STI risk factors, generally make most methods UKMEC1 or 2.
Right. And finally, the notes mentioned learning disabilities briefly.
Yes, and this was about the approach. While LRCs might seem convenient, the crucial point stressed is that assessing competence, like using Fraser principles and supporting individual choice, is paramount.
So not just defaulting to a LRC because someone has a learning disability.
Exactly. Management should be fundamentally similar, focusing on the person's understanding and preferences. Person-centered care, supporting their autonomy, not making assumptions.
That's a really important principle to underline. Okay, wow. We have covered a lot of ground there. From the basic methods and how they work through the Fraser guidelines for young people, and then really digging into that UKMEC framework and applying it across so many different health conditions, identifying those crucial UKMEC 3 and 4 situations.
Yeah, it's complex, isn't it? But having that structured UKMEC approach, like the one outlined in these notes, it's just invaluable for trying to make safe, effective choices with people. Understanding why a method is CAT 1, 2, 3, or 4 for a specific condition is really the key.
Absolutely. So if you are revising this or just need to quickly grasp the key decision points for contraception alongside other medical issues, hopefully this deep dive has given you that high-yield overview, a bit of a shortcut through the dense material, focusing on what these sources say is essential.
It helps link the theory to the clinic room, hopefully.
So what's the final thought? I guess this deep dive really shows how tailored contraceptive advice has to be. It's dynamic, adapting to each person's health, using frameworks like UKMESA. It kind of makes you wonder, how will guidelines evolve next? If we get even more research on specific risks, or maybe as completely new types of contraception come along.
Yeah, it's definitely a field that keeps moving. Always more to learn.
Indeed. Remember, for more high-yield notes and resources like the ones we've been discussing, you can check out PassThemSRA.com and FreemsSRA.com.